I would like to start this with a quotation from Confucius. A solitary orchid stands adorning the side of a mountain, perfumes the air even in the absence of appreciation. But a true scholar, learned in morality and philosophy, is always a gentleman even in the absence of wealth. Now, you have undergone courses in philosophy and yoga, but do you think you will do further work without any compensation?
In this field, yes.
But suppose you are getting, you want to do some work, very good work which will promote bioethics, and you are applying for funding, and that funding has such a structure that you are given some amount at least as compensation for your extra efforts. So, you have different mindsets. Some people are keeping quiet, they are thinking that, well, if I get something, why should I tell here that I would like to have it, isn't it? So, what happens is we have different mindsets, but still if we are governed by some rules, when it comes to money, you need to balance it. And money not only involves the investigator, it is mostly we talk from the participant's point of view, but it is also the investigator who has to be curtailed, because there are companies going to private physicians who are given money per patient. So, that is again another commercial angle to it, and then that person can go into deciding to take extra risk just for the sake of recruiting an increased number, which will naturally fill his kitty. So, that is why the importance comes that it is all clubbed into a common term called generalizable knowledge, that we are doing all this science to promote generalizable knowledge. And we also say that this is to increase the health of the population and all those adjectives. But ultimately it is a participant who is serving as the means in securing your generalizable knowledge. He or she may not benefit or may benefit, or sometimes they may not benefit, but the community from where they come, they may benefit. So, therefore, there is a need to minimize the possibility of exploitation. And how do you ensure that? You already heard quite a bit about it very elaborately, and ultimately here death was the ultimate outcome. So, risk of the highest order. And you also know about Nuremberg Code. I do not have to elaborate that, because Urmila has very efficiently walked you through various guidelines. So, in Nuremberg, it is like experiments where there is an a priori reason to believe that death or disabling injury will occur are forbidden. Then Declaration of Helsinki also talks about it. Here what it emphasizes on the safety of the individual rather than the community. So, actually you will see that some of the guidelines, they speak of the individual's safety, and some of the guidelines they say that individual safety of the individual is important, but if it can also bring benefit to the society, why not? Guidelines with regard to that, Belmont report, Urmila had highlighted quite a bit about it. What about the US federal regulations? It speaks of both, as I told you, both about the individual as well as the society. The sum of both the potential benefits to the individual as well as the that gained by the society. Then COMS, that also speaks, the guideline 14 speaks about that. ICH GCP, it says that now here is what is that foreseeable risk. Unforeseeable risk we do not know. So, that is why they put this word as foreseeable risk. In fact, when we were having public debates on 2000 guideline, this was pointed out, because we had written foreseeable and unforeseeable, and they said you are getting into trouble, because you never can predict what is unforeseeable. Only when it comes to you, you record it and it becomes a matter for the rest of the world to know that, okay, this side effect is seen in this particular situation. So, before a trial is initiated, foreseeable risks and inconveniences should be weighed against the anticipated benefit for the individual trial subject and society. Again, both are combined here, and should be initiated and continued only if the anticipated benefits justify the risk. So, that balance has to be there all the time. And of course, the rights and safety and well-being of the trial subjects are the most important considerations. So, in summary, you can say that the potential risks to individual participants should first be identified. Once you identify them, you have to minimize them, and they should always be proportionate or outweigh the risks. Now, how do you do that? First, you identify the risk and the benefit, what are the types, what is the source, and then you quantify them. It is very difficult for ethics committees to actually have mathematical calculations. A little while later, I will just cite an example as to how you can do that roughly. You have risks on one side, benefits on the other. This is only in proposals where you find a lot of confusion. Otherwise, most of the proposals are straight ones, where you can very easily make out the risk and benefits. But in difficult situations, you can have a tabular form. Somebody can do that exercise and put risks on one side and benefits on the other side, and present it to the ethics committee, and the ethics committee decides what is the action that is to be taken, especially in relation to the community where it is being worked. All those things will come into picture again, and then calculate the probability of harms and benefits to research participants. Now, these can be of the risks could be of different types. Physical risks you can easily make out or anticipate. Psychological risks is something hidden. You never can gauge that, and always whenever we talk about risks, it never comes to our mind except in sensitive situations like HIV, etc., which is very well known because of its confidentiality element, the taboo, the stigma and genetic studies, where you expect this stigmatization. You are sensitive about the issues and you know, yeah, there could be psychological risks. But there are situations, undercurrents, which you never even think of sometimes. One factor which Urmila was telling about autonomy versus harmony of the environment. The reason why this came up was, I was in some discussion and this particular phrase came up, and I highlighted the fact that in our environment it is the mother-in-law culture or the husband's influence mostly taking place, even in societies which was supposed to be matrilineal in their cultural outlook. They have also become very male centric because of our modernization. So, what happens is, if it involves a study on the women, then it is this risk which has to be taken into account much more. Then you have social risks. Your information could cause harm in the employment environment and social discrimination, etc. There is another risk, economic risk, and this is where you generally talk about research participant. You do not talk about situations. For example, you have in AIIMS or any of these big government hospitals, you see outside people waiting, some of them living on the roadside, and they are very adaptive. They bring their stove, they bring, in Delhi during the winter months, they bring their mattresses, everything, and they are lined there on the road footpath, sleeping there and sitting there having tea, coffee, everything. You are very familiar with that. So, we do not think about the economic burden on this side, the whole family, how much it has to spend on that. You are making, you are happily telling the person, you have to come, 1 month later you have to come, otherwise you see, you leave it dash dash dash, but the person understands that either he may not be able to come close to the doctor. Most often it is not only the money which is involved, it is also proximity to the doctor. to clear many doubts, not only his but also his family's. So, these are the other risks involved, and this also happens in rural communities where everything is community based. So, one person gets sick, the whole community or the whole village comes to visit. And then how do you assess that? As I told you, first you identify the direct risk and then you go to the indirect risk. This is what I was telling you, the time away from family, work, risks of travel to the site, etc. Like people visiting the patient in the hospital meet with an accident. What happens? So many situations have happened that way. And then quantify the duration. Of course, that is an exceptional case, but that also if a health economist is involved in this, they will go into that history also. Then quantify the magnitude and duration, classify them as major or minor, either to the individual or to the society. Now, coming to the benefits. Benefits again could be physical, psychological, economic. Physical, of course, is the improvement of disease. Psychological, as I told you, proximity to doctor itself has the placebo effect, and then the feeling of helping others also is there. Some amount of altruism also may be there. And then economic benefits. Economic benefits is put last, but it is a major one, it should come here rather. Then society, the knowledge gained may lead to effective interventions in the future for that community, and it could also lead to change in practice standards. And nowadays that you have this Cochrane library, it does its systematic reviews and then it lays down the standards of practice in that particular disease. Any JM, if you look into that, you have, or you go to this, there is an alert coming from First Watch and all, the First Physician or something like that. It gives you guidelines for treatment of this disease. These are all based on research which has been done in that, which actually changes the practice. So, that is the benefit that the society may have. Here again you can have direct or indirect benefits from the research intervention itself or from the research infrastructure in general. For example, you need to have a CT scan, which generally you will not get it, but if you go to that particular hospital, you can get it done. Or maybe your mother is not well, or your sister or your wife, children are not well. Of course, you can always hobnob with the physician, and physician is interested in having a good follow up. So, that shortcut is made to get investigations done, which is there only in those facilities. So, that is another benefit. Then to the trial period, benefits could be to the participants before and during conduct of the research, or it could be to the community before and during conduct of the research. Can you tell me one example of this? Have you come across any such experience? Benefit to the community before and during conduct of the research, before research.
When there are any trials and community is involved through the community advisory board and through also the community participation, a lot of mobilization takes place. A lot of awareness programs are first there and a lot of support that is there. So sometimes it could be in form of kind of basic health benefits that are given to the community in the very beginning, and also supported sometimes even later on after the trial is over. So this has happened in our trials that took place on the vaccine. HIV
suppose
vaccine
I am a critic of that and I say that, aren't you inducing? How many agree? How many disagree?
There is a conflict here. The conflict is that if we are, as ma'am has told, that we should reach the community before starting a research. If we are not able to give the proper information to the community, we are doing something unethical. Because if you want the participants from a particular community, you should be able to reach that community and you should be able to tell what you are going to do.
That is a different issue. That is a different issue. what I am telling it, what is the benefit that the community
That's
gets?
what, ma'am. When we are doing this exercise of informing the what do you call the informing about the research, the community is able to access of what we are going to do. Like if there is a new drug, what we are what
So
we
that
have
is
for-
actually penetrating a community before you start. But what is the community gaining from that?
Since before starting the trial or the actual intervention, the research team starts going to the community, and whatever problem the community has, they can easily discuss with the research team, or if there is anybody sick, they can always consult the doctors at the community level
So
itself.
you see, if you want to be very unreasonable, you can still call it inducement. But what is your aim ultimately? It is only to improve the health of the population. So I will not consider it as inducement. Okay. This was actually raised in one of the international collaborative, yeah.
Another benefit that I can foresee probably is that in cases of preventable diseases, where the trial is for the patients when the disease has already come in as a cure, but when while propagating this treatment to the community, probably the preventive aspect can start right from there, even before administering the drug. And people could be careful, and the patients who would be contacting the investigators later on would be those who have by chance, even in spite of other preventions and all, got into this disease. So they'll be the more requiring patients to be taken care
This
of.
is another like accessory care or ancillary care.
Yeah.
Okay. So the point is, in this international collaborative study, this anti-malarial agent was to be used. This was for Americans, and it was being tried in a developing country. But then the local community said, we will not do it unless you dig a well here and all those facilities and permanent clinic, etc. And this is done. So some critics said this was inducement to get that. Of course, the other question is that this was done in a developing country population for developed country population. That issue still stands, but it was taken as a case study that in the community you can still do things which have a lasting effect. So even before the project is started or the program starts. And after, of course, as you see, one of our institutions, that institution is for diarrhea and enteric disorders. Similarly, it used to have a field area where it was doing this study, and they were asked to actually, and then when the study was over, they were leaving. So at that time, they were asked to establish a clinic there, outpatient facility or something like that. So the question was asked that this is a research organization, should it go into establishing services? So if you go by present day standards, your obligations are there. So that is after the research has been completed. Then the magnitude, when you are measuring these harms, minimal, grade them or something like that, you would like to see which is better with regard to the magnitude of the potential harm. So whether you would take as the criteria compared to slight discomfort, or whether cure versus tumor shrinkage in case of cancers, and then quantify the duration, whether you would like to foresee that it could do harm one time versus long time harm, like the effect of a drug for a long time, indirect from the treatment as in cancer, like acute infection versus chronic fatigue. So like that you have to classify them. You are still in haze, you really do not know how to make decisions. But then you could discuss how you could reduce the risk and enhance benefits. So you could conduct research consistent with the standards prevalent at that point of time. Now if somebody goes for to court for an incident which had happened 10 years ago, then the court will actually apply. You cannot argue with today's standard. It will go into what the standards were 10 years ago. So, the present standards whatever are applicable, one has to conduct research consistent with that, and you can see if the procedures could be substituted, less harmful, and of course, qualified personnel without doubt you have to have them. And then monitoring, if you expect that there will be harm, then you have to constantly monitor, and the moment you find that something is going wrong, you can stop. And if this is happening in number of patients in the research project, the project itself can stop. One of the stopping rules. So, now actually according to the CONCERT guidelines, you have that one heading called the stopping rules. Suppose there is a less harmful procedure and it can give you the same result, then you can substitute that. Then of course, subjects, when you ask the subject, they will always go in for the experiment, because especially in conditions like cancer, HIV, they are so hopeless about the future that they will easily go in for such experiments.
Whenever we have the substitution of procedures, any kind of substitution of procedures again would require the ethical clearance. Each time there is
That goes without saying, but that will be covered in that particular. Then one also has to consider whether it is to the individuals or to the society. That is knowledge gained plus benefit to participants, or sometimes people also say that the resources, whatever limited resources are there, should it be wasted for that. So, that is where the community becomes important. Now, for an example, you already know about what phase 1 is. Everybody clear about phase 1? Healthy volunteers, they are going into the study with their eyes open. Now, a study in oncology. This is just an example how you can tabulate that. On one side you have the risk and on the other side you have the benefit. The risk is that in the literature you find a death rate of 0.5 to 0.7%. On the other hand, you also have a meta-analysis. What I was telling you about the Cochrane library, the systemic reviews. Nowadays it has become a fashion to have meta-analysis. Meta-analysis actually brings out, it finally leads to change in clinical standards for practice. So, it has shown that response rate is about 5%. On one side you have 0.5% death, on the other side positive response 5%. If you had only these to compare, what would be your decision? Benefit is more than risk. Okay. Now, side effects such as hair loss, nausea, vomiting, blah 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 is not quantified. It is known to be severe, but it is not quantified. Here of course, this is an extension to that the response rate in a more recent study was even more. And then there were notable responses in a few studies. This is just an example. The other point that was given in that particular article was resource and time commitment from patients and families due to frequent blood draws, radiological evaluation. What I was telling you, that the whole family gets involved, how much that is involved. And then some data indicates psychological benefit from participating in phase 1 studies. These are the facts. Now tell me whether there is more risk or benefit. Benefits are more. What about this? The cancer treatment, as you know, is costly, okay, and this adds to that cost. One will have to decide whether the participants have to be subjected to this cost as well as the cost of the treatment to the foreseen benefits. So, the ethics committee will have to decide that.
The cost is borne by the patient?
That again depends on from hospital to hospital. In government hospitals you may get it partially met or fully met, and in private hospitals naturally, but then in private hospitals you won't have the whole family coming and sitting there, that is also there. Then what standards after this this is just an illustration. You have to consider what is the baseline mortality in those particular cases wherever it is outlined. Then consider alternatives including prognosis, and then minimal harm or risk of daily life. Now, this risk of daily life is something very dicey, because there is a lot of difference between the daily life work of a clerk, of a doctor, of a mechanic, isn't it? The other day I was getting my car repaired for something. The mechanic went underneath, they lie down under that. He was trying to fix some engine or something like that. It fell on his chest. So, that was supposed to be a minimal harm earlier. I mean, you can expect your screwdriver to fall and all those things, but a heavier thing falling is not a expected thing. So, that is how you have to weigh what is the risk in this particular case. Whereas in cancer, the patient is already on risk. Any time the person can pop off, already on chemotherapy, but you are adding one anti-nausea drug, you want to compare it. So, now in that person who is running a high risk, even otherwise, you are adding another one. Will this be high risk or low risk, minimal harm or more harm? I just wanted to make this point because this is there in our guidelines, how you describe. See, minimal risk requirement came from US anyway. The probability and magnitude of harm or discomfort anticipated in the research are not greater in and of themselves than those ordinarily encountered in daily life or during routine performance of physical or psychological examination or tests. This is the definition, but you have to weigh it on case by case basis. As you have now well understood that in cancer patients or HIV patients, etc., who are already at high risk, if you are giving an intervention which is not ordinarily supposed to cause high harm, it is minimal risk. So, who decides this? There are various people who can decide that. The investigator can decide that, bioethicists can argue on that, lawyers can say no, my patient underwent a lot of torture, he will write a compensation clause also. Then statisticians, they will say no, we can't go ahead with that. Physicians themselves may be skeptic. Policy makers would say no, you see, you are giving this drug to these patients and 50% of them are dying, how can we take a policy out like that? So, policy makers are equally responsible. Patients, as I told you already, their opinions could be very, very limited in value because of their interest in getting treatment. So, we have to actually balance the scientific value with the risks and benefits. There is always an inherent tension between gaining knowledge and minimizing risk, and frequently increasing risk increases opportunity to gain knowledge, that is always there, but one has to be always cautious. One has to see that there is not no exploitation. So, actually the onus of the whole thing goes more on the shoulders of the ethics committee members. And according to Angel, demonstrating the safety and effectiveness of a drug or a device does not of course mean or showing that there are no side effects or risks. This is the same person who gave up her editorship of NEJM on the AZT trial issue. There were a number of opposite views also on that, as she was telling whether the same standards could be applied globally. And there were people from my batch from the African countries, they were saying the developed country the course mates, they said that no, how could we do like this, the standards should have been same, how can we have two criteria for such a thing. Then these guys, they got up and then they said, what are you talking about, there is absolutely no drug available in our country. So, even if it comes in the form of research, at least for some time our people will get it. So, you see the psyche, it is always based on circumstances. If that were the standard, we would have no drugs or devices, since nearly all of them have potential or possible side effects. The issue is the balance between risks and benefits, and even in Ayurveda they say, you know, everything on earth is poisonous actually. How you use it, it turns into a medicinal value. Greater risks are permitted for greater benefits. In evaluation of the balance, risks and benefits are usually considered separately, then weighed. Now, anyway, whatever framework you may have, whatever theoretical framework you may have, whatever ethical principles you may have, you may hammer through all these, but still it becomes very, very difficult when you try to practically apply it, and creates difficult ethical situations many a times. And for you all, if the local ethics committee finds it very difficult to decide on a particular issue, you can always, you know, approach the National Ethics Committee or people like us who are centrally placed. So, in summary, inherent uncertainty about the degree of risks and benefits is always there, but despite the importance, sometimes assessment becomes very complex, and no simple formula actually you can evolve to decide on the risk benefit ratio. Risks and benefits need to be identified, quantified and calculated for probability of beneficial risk ratio. In fact, there were these statisticians, some of them who heard it, they were so enthusiastic, they say, ma'am, can we work out a proposal where we can actually, because you see, from what you heard from Pravesh Gole, you can see very easily how mathematics and philosophy and everything was interconnected. And earlier days, these philosophers, the fathers, they were so knowledgeable, they applied maths, everything. So, again we go back to the same thing, like the statisticians coming into the picture and saying that we could devise formula. In fact, one ethics committee, one paper was there where something of this sort was calculated. And you also have like you have ratios, benefits on one side and harm on other side. You give grading, minimal, maximum, and how much 2 points for benefit, 2 points for harm, like that, you know, you calculate and come to a conclusion. Anyway, it is not so complicated as I am telling you, it is common sense. And the people who are together, they put their head together, you get all sorts of views and come to a decision. So, that way you expect that there is some protection of the individual. I would like to state here one fact, it is there in your readings, this benefit. One woman who was under depression was asked if she would like to be participant in a research project where they are giving some other drug to bring her up. She said, what is the percentage of harm in this? He said 1 in 3,000, some figure he gave. Then she said, I would not like to join because I would like to be that one person. So, you do not have answers sometimes.
But in the example case which you gave, the risk was 0.5 to 0.7%, which translates to 1 in 200 antiemetic. Cancer patient taking an antiemetic is having another option which is more
No,
safe.
this was not antiemetic. Antiemetic was another issue that I brought up.
I think it is significant if it was an antiemetic.
Even if it is antiemetic,
1
if
in
it can,
200 going to die.
yeah. So, that is how you calculate. You feel it is more risky or less risky? 0.5%?
If it is an antiemetic, I think it is more risky.
That is what he was trying to say.
This is the case of my dad, who recently expired. He was suffering from prostate cancer, which was in the advanced stage, and then it got metastasis to the bone. We had a kind of this risk-benefit, ratio. What actually all we relatives, we look into that he should get some, we should do something to him. But what he was a very strong man, of course. What he insisted is that, no, I don't want to take chemotherapy, I don't want to take radiation or anything, just leave me like that. And just what we did is, we took him for a scan in one of the big hospitals, and they did it, and he said, never again take to me a hospital. And we had just put him in at home as to the patient's will. And of course, some of the drugs helped him so that the pain was not there till the end, and he passed away.
That
So-
is actually, see here again there is a cultural difference. Like in foreign countries, you are not allowed to die properly with dignity. That is how the whole process of living will and all those things, you know, end of life issues came up. And in fact, when I was in Toronto, this was some person who had worked among Chinese. Because there are very odd people, no, you can count them on fingers who have worked with such communities, they are considered to be experts. So, this presentation was made in our class, and it was very easy. Like Indians, among Indians, most of them want to go back to their homes, die in peace. That is the norm, general norm, but there it is just the opposite. And then you have social security people also coming into the picture and taking you and all those things. There was a poignant presentation by one of our course mates who related the story of a very old couple, and she was on call as a clinical ethics person. So, she went there and she said the man was tending the garden looked very nice, and then she went inside. She said, where is the patient, because it was all so dark and it was very smelly, and he said, there she is. And she went, old woman bent like that, and she tried to talk, she could not talk much, and then she tried to see what was wrong, and then she opened, very flabby naturally because of that, and she opened her mouth, and she actually, when she was relating, she was preventing herself from crying and feeling so, you know, repugnant of the whole scene. Her mouth was full of fungus, and that was mainly because the husband could not push food into the mouth, and she was not swallowing, so it was staying there. Like that was the situation. And then slowly she came and she tended to the patient and all those things, talked to the husband and all that. And actually husband and wife had very close relationship, and if that woman had passed away, this fellow would have been actually devastated. But he was carrying on his routine work. So, different people behave in a different way, you know, trying to get over their grief. And then later it came to a stage that the woman started eating and sitting and talking. So, that was mainly because of the intervention of this person. There are situations like this also, where you have the state coming into the picture, and just because this lady was a very compassionate one, it is okay. But suppose a nurse had gone who does not want to do things, you know, and you can expect what would have happened.
Ma'am, one question please. Who testify or authenticate the risks or the risks or benefits declared by the investigator, because he may say so many other things when you go to the field.
To the field?
Yes. Who testify or
No. Before the person goes to the field, he has to submit the proposal to the ethics committee. There is a whole patient information sheet, or if it is not a drug trial also, you can combine the two as a lengthy informed consent. So, in that informed consent you explain all these things, and this is supposed to be digested by the participant. Okay, but you know, not only in our country, but even in Western country, this is what is happening. Like you have ethnic groups there, and Chinese are there all over the place, and these people are not even educated as we are. So, they do not understand anything else apart from Chinese. And what happens is, if somebody goes along with them who understands the thing, most often in universities it will be the students who go along and all that. And then when the doctor explains everything and all that, even with the people who understand, you know, 15, have you seen drug trial protocols? You have ranging from 10 to 25 pages. Okay, the doctor is expected to read through, but it does not happen. So, you are supposed to give a copy of that to the person, that is in drug trials. You are supposed to give a copy. They take it to whichever place they want to take it and get it read and make them understand and all that, and they are supposed to bring it back. At least in India, people are doing that, clinical pharmacologists and all that. But this one, at the end of all that narration, whatever, he may have skipped pages also, but after the narration, the patient still asks, must have slept through the whole thing, and then says, okay doctor, what do you feel is right? Should I join or not? So, it comes to the same thing. So, it is actually from the legal requirement, but if you are really sincere, I remember as a researcher, I used to talk more than half an hour, and I was working in a general hospital where you have on admission days, you have patients under the bed, fight out the bed, over the bed, all those things. And I did not even have a chair to sit sometimes. So, you need to talk to the person who is supposed to be inducted in my study, and it is a viral hepatitis study, acute hepatitis, and of duration 10 days. So, you do not expect that the patient is in a grave situation or anything like that. So, you talk to the person for more than half an hour. This is Dr. Satyavati's program. So, she had all informed consent, everything ready. Of course, if you look at the informed consent now, it is much more, but those days, and explain everything, and then the person says, you are not going to give drip? No, I can't give you drip, this is only capsules. Then why did we come here? The whole family will be there. Then why did we come here? And they go. Okay. You lose your case, but you are doing sincere work there. But there are centers where they do not explain so much, their entry number will be much more, and then people would say, oh see, that center is doing well. It has inducted, what are you doing? You do very slow. So, what your natural tendency becomes, either you are hurt, or you think if you are more cunning, you will think that they want numbers, I will show next time. Next month they will have 60 instead of 20. Like that, no? The psyche goes that way. Thank you, Chairman, and thank you for your patience.